Yes, with the part one, we did what we call headaches, and then we are able to define headache in two ways. We said one is primary, one is what secondary, and we discussed the secondary headache into details where we spoke about the characteristics and the red flags in secondary headaches. Those things that you experience, and then you need to ask yourself questions where this particular headache is coming from. I mean, you think we spoke about it, and we even use an acronym for it where we called what POMPOS. We look at the positioner, we look at the onset of the headache, we looked at the systemic symptoms of the headache, we looked at the aggravating factors of the headache. All right, and in all, we realize that when you experience any kind of headache that has those characteristics, then basically we are pointing to what we call the secondary headache. And then I assured you that there is going to be a video on what primary headaches. Now there are about three primary headaches we have, and these are the in this particular video we are only going to take one of them and then what discuss. As I have arranged them on the board, I mean, you see primary headaches here boldly written, and then let me let me get this from there. All right. So you see primary headaches here boldly written, and then we have what you call under the primary headache. We have three of them, three basic primary headaches. We have tension headache, we have migraine, and then we have cluster headaches. Now let me talk to you about something. We define the secondary headache as a type of headache that actually has a defined cause, has a true defined cause. So there is something basically causing that particular headache. It can't just happen like that. You understand? You can't just be well and all of a sudden you start suffering from what one particular severe headache that is positional. I mean, there should be some questions you're going to ask yourself. All right. So primary headaches, the difference is that primary headaches has no defined cause. We've not been it's the type of headache that is basically not going to give you any particular cause. That's going to basically not going to direct you to any particular what source or cause. You understand? So it has no defined cause. At the end of the day, there is no pathology to it. That's basically what I want to say. We defined the pathology last time. We said what? There's an abnormal what? Tissue, physical damage to a particular what? Tissue. You understand? So primary headaches have no what? True defined cause. And when you come under primary headaches, in simple terms, you have what you call the tension headaches, you have what you call the migraine, you have what you call the cluster headaches. When you look at this, it's arranged in order of how prevalent they are. So we have tension headache to be very, very common. But I mean, in your mind, you might think it's migraine because migraine is basically what you have heard. I mean, anyone suffering from headache, which basically they treat and it doesn't go, they blame migraine for it. Understand? But then that's basically the second most common type of headache we've been experiencing. Then cluster headaches. That this is very, very less common. We don't usually see these things. People do not usually go through this thing. But not to say that completely we don't see it. We see it, but then it's not that common. Understand? So we have tension headache, migraine, and what? Cluster headache. For the purpose of this particular discussion, we are going to take what migraine headache is. We are going to discuss migraine headache. We are basically going to go through tension headache. But because tension headache is very common, but migraine is very common in our minds. Any particular headache we feel like we have no true defined cause to it, we tend to blame migraine for it. Let's get to see whether some of the headaches we have in the past diagnosed as migraine, or we have in the past self-medicated ourselves thinking it was migraine. Let's get into whether we will actually get to we will actually get to realize what we did. All right. So basically, when we talk about primary headaches, it basically means that there is a physiological cause. It's nothing like a physical cause. So let's take the brain for example. Last time we spoke about the particular agitation of vessels, stimulation of vessels, and distraction of vessels leading to headache. And all these vessels, we spoke about the fact that they are around the neck and the brain. Understand? I mean, in any situation, the brain is undergoing activities. The only function of the brain is basically to move the body about. So you moving about up and down and things is all because of the brain. You understand? At the end of the day, It's as a result of nerve neuron transmission, nerve system transmission. The nerve signals will be sent from one part of the brain cells to the other part of the brain cells for signals to be sent to the particular place that the brain wants to instruct to undergo certain activities. So in all, we're just talking about neural transmission from one point to another. If in any of these events the transmission is distracted by anything, it could be hormonal, it could be some physiological, any form of physiological event that may distract the neural transmission, then basically you are kind of going to have agitation to these vessels, and then you are going to get to suffer from any kind of this what headaches on the board. All right, so let's get into migraine. So let's say with migraine, we have about four phases that you are going to go through to realize that now this particular headache is this migraine in question. Right, so we have the what we call the prodrome phase, we have what we call the oral phase, we have what we call the headache phase, and then we have what we call the post-drum phase. We are going to talk about each of them. When you look at the post-drum phase, it takes hours to days to what to occur. It can last for hours to days when you are suffering from migraine and the post-drum phase. And then when we come to the oral phase, have about what 5 to 60 what minutes. I mean, it can disappear. You understand? Within 5 minutes, and it can also stay within 5 minutes to what to 60 minutes. Then we have what the headache phase. That is the most intense phase. That is where you get to suffer from the actual migraine. So that can last for what 4 to 72 hours. Then we have the post-drawn phase. That's basically going to give you a lasting phase of what 24 to 48 hours. Like I said, we are going to get into all of this. So with let's take the first one, the post-drawn phase. Let me take this one. I mean, there are a lot of things on the board, but just focus on where I am. Right now, I'm here. We've spoken about this. Now I'm here. We will get to this, so don't pay attention to this side too much. When we get there, you will understand. All right, the program phase. Like I said, before anything, there should be a signal to you. When we spoke about the secondary headache, we basically said that it's very sudden. It has a very sudden onset, unexpected onset. But this particular one, you are going to expect it due to the things you go through before the actual headache do occur. So that's the program phase. In that particular phase, you feel fatigue. That is where you start yawning. They are like subtle symptoms, non-specific. You basically like you feel like there is something actually wrong with you, but the actual thing hasn't appeared yet. So you begin to feel weak, moodiness, yawning. All of these things happen at the post-drawn phase, and this can take hours to days to occur. You understand? Then at this phase, you are likely to blame a whole lot of conditions for this. You can even go and buy malaria medications. You can even go and buy typhoid. That's where most of the clients will come and they are like, I think this when I'm about to have typhoid, this is what the things I go through. So I went to the pharmacy, I went to the drugstore to purchase some typhoid medications to take. Some people might even tell you that they've taken herbal medication, but yes, though it's not working. Then days later, they will come back to tell you that they've been having visual changes, short-term visual changes. Basically, you see cloudiness in your eye, blind spots. You're going to have a vision that looks like a zigzag. Sometimes you even tend to go to the washroom, wash your face, thinking that all these things will disappear, but then it won't. Until it gets to the point itself wants to what disappear. So that's the oral phase, 5 to 60 minutes. You begin to have short-term visual changes. You have zigzag visions, you have blind spots. You can even get to the point of feeling dizzy, vertigo. You can have imbalance in movement. It's very very distracting. So at the end of the day, you are kind of basically going to blame a condition for it. It's a disease process, and the normal history of the disease needs to take place. So you started with the fact that you are feeling fatigue, you are yawning, you are very moody, and then subsequently came to the point where you started having short-term visual changes, zigzag visions, blind spots, dizziness, vertigo, like a whole lot of things. You basically going to blame something for it. And by the time they get to this point, if they have not taken any medication, at least malaria medication that they've taken it, they will go and do the test, it will be negative. They will do a typhoid test, it will be negative. They will still blame the fact that when they have malaria, this is how they suffer the symptoms. All right. Then we get to this headache side, this is the actual phase which will bring them to the hospital. The actual phase that, I mean, when you take 10 patients coming to the hospital or 10 clients coming to the hospital, about 6 to 7 of them are coming because of pain. If they don't get to the point where there is pain, they are likely not to come. So this is what is going to bring them to the hospital. The headache phase, which lasts for about 4 to what, 72 hours. A very severe pounding headache that is one-sided, unilateral. So very severe pounding headache that is one-sided or unilateral. With that particular headache, when a child is even passing through the side of the patient or where the person is sitting or standing or probably trying to relax, the child even makes a certain noise, makes some form of noise, this person is going to get irritated. This is how migraine occurs. So they get irritated by sound, they get irritated by light. And when they are in the room and you switch on the light, they will quickly ask you to what? Off the light, because they become very, very photosensitive. So noise and then light, they become irritated by these two things. So when you even shout, when there is a noise, you try to play music around them, they become very, very distractive. They warn you to stop, because they are going through a whole lot of what stuff in their head. So this is a very, very intense phase that will bring them to hospital. So take note of that. So there is a pounding, that's a the baby boom, tiny boom, pounding, very severe what headache. That is one-sided. So you take note of that. Then get to the postdrome phase. So after they've gone through all of these things, within the next 24 to 48 hours, then they become like they've had a hangover, like they are too tired, they are too messed up. You don't even know what's wrong with them. You understand? By this, if they don't come to hospital through this, they may have taken a whole lot of medications, antibiotics, antipyretics, um, a whole lot of medications, you understand, before they come. So by the time they come, basically the normal history of the condition has even passed. You do all kinds of labs and everything is normal. You get to know that what it is, what migraine. The key word is what? Pounding unilateral headache. Very severe pounding unilateral headache. So this is basically how migraine do what? Okay. Don't forget the oral phase where you have this zigzag vision, blind spot, and cloudy vision. They will tend to even go and wash their face thinking that those cloudy visions and zigzag will disappear. Alright, so yes. Now when this thing occurs for a very long time, so let's take within a month, the patient has a migraine that has occurred maybe about 15 times. That is what? 15 times or more. That's a what? Chronic what? Migraine. A migraine that has occurred in the person's life for about 15 times in a month. That's a chronic migraine. If it's less than 15 times, it's called episodic migraine. But then once it occurs more than 15 times a month, it's called what? Chronic migraine. Some people might come to hospitals with that, with migraine occurring more than 15 times in that month. They might have told, they will basically tell you how many medications they've taken and yet it's not resolving or it's not improving. People who are very clear about their health and they know what they want to do, they will basically come to hospital when it even occurs once. But those people who are very stubborn and those medications, they will take them. All right, then we have what we call the status migrainosus. This one is a very severe form of migraine whereby regardless of the medications you have given, it's not resolving. Very severe form of this, regardless of the medications you've given, it's not improving. Then we diagnose as what? Status migrainosus. It can last for 72 hours. It's a very severe form. You can't even you are giving the medication, it's not working. Within 72 hours, you have not achieved your aim. That is what status migrainosus. So when you get patients like that, I mean, this is basically should tell you something to improve on what? On your medications. Then we can have migraine that is coming without this oral phase. You can have a migraine that is coming without this oral phase. Migraine coming without this phase, without this short-term visual changes. So basically, they might suffer from the prodrome phase. They might suffer from the severe, intense headache phase and the post-drome phase without without the cloudy vision, the nausea, the vertigo, the vomiting, all of that. People can have migraine without it. So migraine without aura, and then we have migraine with what? Aura phase. So understand these things. So it's normal for someone to have migraine and start vomiting. So basically, you don't think that it's not migraine, it's some infection that is worrying the person. The fact that they are vomiting, understand? So it's very good you understand this particular phase. Then you begin to give all forms of antibiotics just because they are vomiting. Sometimes you even start to treat ulcer for that. All right. So these are the risk factors to migraine, to people suffering from all of these things. Like I said, we have no true defined cause to this condition. So this I call them the three C's. You understand? Three C's. So we have people who are very addicted to chocolate, people who are very addicted to cheese, and then people who are on what OCPs, contraceptives. And then we have what people who tend not to have very adequate sleep, or basically they have too much. Sometimes you can even sleep to the point you even get tired of the sleep. You have nothing to do. You are just in the room sleeping, waking and sleeping, waking and sleeping, waking and you get too tired. You can suffer from migraine. Too much of everything is bad. Take note. So little sleep or too much sleep can lead you to what? Migraine. So the three C's, the S at the end of the C's is basically the sleep. You have chocolate, cheese, contraceptives, and what? Little sleep or too much sleep. Those are the risk factors. So people who are very much exposed to these four things stand a chance or stand the risk of what? Getting migraine. Treatment. I'm not here to mention drugs. I mean, due to abuse. So basically, I'll leave those who understand the terms to deal with it. As the point you start mentioning, these drugs can be addictive, you understand? So you stand a point of putting people at risk. So yes, non-opioids and what triptans, or you can use both. Or sometimes you can use what? If it gets to the point where we are getting to status migrainosus, within 72 hours, we have not been able to achieve our aim, we have not been able to improve the symptoms, we can get to the opioid side and then try to relieve the person. So yes, this is migraine. Our next topic is going to be on tension headache, the very most common type of primary headache. So I hope you get this, I hope you understand this. Just stay tuned. O.M.A Medical Studio will come your way again.